Thank you, Corey. So Dr. Evans gave a nice review about mutational landscape and the advances that have been occurring in T790M positive disease. I just wanted to also briefly illustrate that, what she spoke about comprises about 50% of the resistance mutations to EGFR tyrosine kinase inhibitors. There are other potential mechanisms that encompass the T790M negative space, including MET amplification, which can occur in about 5% of these patients, PI3 kinase mutations, which can occur in about 5%. And she alluded to small cell transformation, which was initially reported to be 14%, but I think in practice is likely not that high in our clinical experience. And these are agents, first and second generation tyrosine kinase inhibitors, which have been developed in this disease, and Tracy already went through a lot of these. And you can see many of the later agents in development were designed to target the mutants, be mutant selective inhibitors. And the result is, as I'll illustrate, differences in activity in the T790M positive and negative populations. I wanted to start with reviewing the IMPRESS trial. Before this trial was reported, a question in the field was, is there a role to continue the tyrosine kinase inhibitor with chemotherapy if somebody progresses initially? And so in this trial, patients who were chemotherapy naive, who had progression on a first-line Afatinib in this study, were randomized to either cisplatin and pemetrexed and Afatinib or cisplatin and pemetrexed. And the primary endpoint was progression-free survival, which you can see was not met, as the PFS in both groups was very similar. They did look at the T790M status in a circulating DNA biomarker analysis. There was some slight imbalance between the two groups. 40% in this study were determined to be T790M negative. And in looking at the subsets, in the side I kept the T790M positive. You can see there was no effect on progression-free survival. The blue is the Afatinib treated group, the ones that remained on Afatinib. And while it was not statistically significant, there was a slight superiority in the PFS with the T790M patients who received Afatinib versus those who had only with chemotherapy versus those who only had cytotoxic therapy. But the numbers are small, and there was no difference in overall survival. So even for the T790M negative population, we would not continue the TKI with chemotherapy at progression. But I think this is sort of interesting and maybe something to hypothesize for future studies if there's a population of these patients who may still be having benefit if they don't have T790M positive resistance. And the response rates had similar trends to the PFS, where in the T790M negative population, there actually was a little bit higher response rate of 37% versus 28% in the group who continued the EGFR tyrosine kinase inhibitor. Again, though, our standard practice is to not continue at progression if somebody is being placed on chemotherapy. Another trial that's been done years ago now to evaluate treatment options for this resistant population are the Afatinib plus Cetuximab study. And in this phase 1/2 study, it was initially reported at a time before we had data with second-generation tyrosine kinase inhibitors. And so everyone was intrigued by the responses seen with this combination. It is associated with toxicity. You can imagine if you're combining two agents that target EGFR, there is potential for more skin toxicity. The response rate in the T790M negative group in this trial was 25%, and so there was there's some suggestion of activity, but with the advent of next generation agents, this wasn't really a combination that was developed further in larger studies. Tracy already spoke about osimertinib and showed the waterfall plot for T790M positive, so I'll show it now for the T790M negative. And you can see that there were some responses in this population, but not to the degree that we see with the T790M positive. And when you look at the progression-free survival, clearly the T790M positive group of patients is having more benefit, and that's why it's indicated for this group of agents rather than the T790M negative disease. And we are also already spoke how the HM61713 is no longer in development. In the phase 1 trial, though, as you can see, there was also some small degree of activity, about 11.8%. In the T790M negative disease. So all of these second-generation agents with the hope of targeting resistance mutations, while there are some signs of responses in a small percentage of patients, in general, these agents seem to work better for the T790M positive population. And again, this is the PFS from that agent as well. So, and this overview just illustrates again the difference in response rates we're seeing. And so it leaves us then with the question, what do we do for this patient population? In the excitement about immunotherapy, combination studies are starting to be reported. And this one, I think, is one of the first trials with a tyrosine kinase inhibitor and durvalumab, which was stopped early, and I think is a lesson for all of us. In this study, which was the TATAN study, was designed as a multi-arm study looking at different combinations of durvalumab with tyrosine kinase inhibitors, and one was with osimertinib. The rate of pneumonitis was about 38% in this study. They were not all grade 3-4, but it was certainly higher than what we would expect with each single agent alone. They also did have some early signs of activity, and the response rate in the T790M negative group was about 21%. So not greater than what we're seeing with the second-generation tyrosine kinase inhibitors on its own. And with the concerns about toxicity, it leaves us questions how to develop the strategy of combinations of tyrosine kinase inhibitors and immunotherapy further in coming studies. So for the clinical management of these patients, where does this leave us right now? So for a patient who initially was treated on a first-generation agent who has progression, as Tracy alluded to, in scenarios where there may be oligo progression, there is a role sometimes to give a local therapy and continue the first-generation tyrosine kinase inhibitor. The standard in somebody who's having multiple areas of progression and who really does need to change therapy, I think for the T790M population, remains platinum doublet therapy for those who are chemotherapy naive. And so in that sense, I think they fall into the algorithm that we employ for many of our patients who are initially presented with mutation-negative disease. It is important to consider rebiopsies over time, and I think the challenge with the new circulating assays, as Tracy mentioned, is the risk of false negatives. And so in a patient who can have an actual biopsy of tumor, that's something to consider. One, to look for small cell transformation, and two, to make sure that the results are reproducible. There was an abstract at ASCO this past year by Tanaka and colleagues of a Japanese study where they looked at the rate of T790M positivity over time in patients who were treated with EGFR inhibitors who had EGFR mutations at initial presentation. And the percentage of having a T790M positive disease seemed greater over time, as high as 89% in those who had been on a TKI for 4 to 5 years. They had serial biopsies on 9 patients, and 5 of them were initially T790M negative and then eventually became T790M positive. So I think it's important to keep in mind for patients who are doing well to eventually maybe reconsider another biopsy and retesting, because if they do have immersion of T790M on a subsequent specimen, then they at least have the option treatment of osimertinib. So don't always just use the first testing as the decision point. Reconsider trying to look again. This is an area where patients should be considered for clinical trials, and I'm going to discuss a few that are ongoing right now. And again, Tracy already mentioned the concerns we have with immunotherapy. The numbers are small and the data is early, but it's not clear how that's going to fit into this population. So ongoing studies. Currently, a phase 2 study that is ongoing studies the agent Taroxetinib, or TH4000, which is specifically for EGFR mutant T790-negative patients who've progressed on a TKI. This agent is a prodrug which is activated under hypoxic conditions, and so the rationale is to have increased activity in a hypoxic environment. And I believe this, Corey, you have this open at Penn? No? Okay, I thought it was, but never mind. Oh, you had it, got it. And then, as I mentioned before, there are other pathways which are potential targets in this disease, including PI3 kinase mutations, which can occur in about 5% of TKI-resistant tumors. Early efforts to study agents, one was by Lara and colleagues, where they looked at the AKT inhibitor MK2206. In that trial, the response rate was 9%. There's an ongoing study with the combination of erlotinib and the PI3 kinase inhibitor BKM120. And then finally, the role of MET inhibition has been evaluated in this disease. There was a paper in PNAS by Bean and colleagues which showed that MET amplification seems to be independent of T790M status in TKI-resistant patients. So perhaps this is something to look at specifically in this population rather than the whole group of resistant tumors. The Geometry study is a phase 1b/2 multi-center trial of an oral MET inhibitor plus or minus erlotinib versus platinum and pemetrexed in patients who had EGFR-mutated c-MET amplified lung cancer and acquired resistance to a prior TKI. Potentially another option for study. But I think there's a lot that still really needs to be evaluated to fill in that half of the pie in this T790M group, which is not enjoying the same benefit to a second-generation agent as the positive population is.